health promotion activities in general. For example, things that we do to alleviate the common discomfort of pregnancy. When you're tired, what should you do? Sleep. You should rest. When you're constipated, you should increase your fluid. You should eat fruits and vegetables. So you know these things, and we just have to apply them in the context of pregnancy. We will talk about some self-care actions that women can do, and again, thinking about it in terms of trimesters. We'll talk about some substances like tobacco, alcohol, and then the very last thing is talking about risk factors for particularly women over the age of 35. So in different resources, you'll see that upper age limit, like advanced maternal age. So we in OB may call that AMA. You may think of AMA differently from Med-Surg land, like against medical advice. So people who just got up and left and didn't. We can also have that in OB. But when we talk about advanced maternal age, some folks say 35, some folks say 40. I think as women are delaying childbirth and we have more data about women having babies over the age of 35, it would not surprise me to see this age limit change, okay? But it's when you have a relatively small amount of women having babies after age 35, when you see twins, when you see babies born with genetic disease, when you see health conditions like diabetes, preeclampsia, that certainly raises concerns. Now, on the flip side, women sometimes in the pregnancy less healthy than they used to. They have risky behaviors. You have women who have high cholesterol, hypertension, diabetes in their 20s rather than in their 40s. So if you come in with kind of a pre-existing health condition in pregnancy, that certainly increases the risk of complications. Can you all see that okay? Or do I need to dim the light? It seems really hard to see. Somebody back there hit, I don't know which bank of light, maybe because the glass or maybe it's super sunny. If you can hit a bank of lights for me. Is that my only choice? Oh wait, there's one up here. Maybe this. Yeah, I think that's better. What do you guys think? Okay. So this is from the textbook, and these are pretty densely informative tables and charts. This talks about what you would teach during pregnancy. So notice during all trimesters of pregnancy, we talk about kind of the normal discomforts. We're always talking about nutrition and weight gain. Okay, so nutrition and weight gain is something that is extremely important, and we'll talk about very shortly. Weight gain in pregnancy is not the same every trimester. So obviously, if I'm having a lot of nausea and vomiting in the beginning, I don't have as much weight gain as I would if I didn't have nausea and vomiting. The other thing is you have to think about what's going on with the baby. While the first trimester is the most risky period of time for fetal development, the baby's not accumulating a lot of mass at that time. Okay? And then the other thing you got to think about is our friend fluid and electrolytes. Fluid and electrolytes get altered as you progress in pregnancy, and that certainly contributes to weight. So in the first trimester, we talk about your attitude towards pregnancy, exercise, avoiding risky things. Fetal growth and development is huge. And so it's having a good healthy diet, and if I had to prioritize, it would be folic acid, iron, and protein. Those would be the big ones. Calcium would also probably be in the mix as well. But sometimes in the first trimester, you eat what you can eat so that you just don't kind of get sick and lose weight. In terms of danger signs, remember that in the first trimester, we really can't do much. So if you have bleeding or spotting or cramping, you do want to let your provider know about it. More often than not, what they usually say is rest. And if it goes away with rest, then hopefully it kind of resolves. If it gets worse and you start bleeding heavier, then you need to come in and be evaluated. And they usually will come and see you as the ER nurse. In second trimester, that tends to be a little bit easier. Kind of the hormones are not as fluctuating as much in second trimester. The baby's not so big that it's causing a lot of physical discomfort. So in second trimester, it's kind of the pause. Patients are feeling better. And remember, first trimester is about the first 13-ish weeks or so. Second trimester, there we go, is somewhere around 13-ish to 27-ish weeks or so. In second trimester, you're coming to the doctor once a month, or the midwife once a month. And so the big thing that should happen during that time frame is fetal movement. So that's, again, around 20 weeks or so. We're looking to make sure that the baby's moving. It's at this time that you certainly want to be talking with moms in this point in pregnancy are going to pregnancy classes, I would not have them going to childbirth classes. Childbirth classes tend to be reserved for third trimester. And the reason why is because we want to get a little bit closer to the end. A lot of times we have some idea about what the plan is in terms of is the patient having a vaginal delivery or a C-section. You'll notice that in the third trimester, not only do parents need to decide about the childbirth plans, but they also need to be thinking about the baby. So you may ask questions about, are you going to breast or bottle feed? Do you want the baby circumcised? Are you thinking about a pediatrician? Believe it or not, even when you're pregnant, you need to be thinking about child care and how you're going to care for your baby after you go back to work. For some facilities here locally, you have to be on a wait list like 6 months. So you actually get on the wait list for your child care when you're pregnant, so that there's a spot open 12 weeks after you have a baby. I think the other thing is we certainly want to recognize that in third trimester there are more physical complaints. And I think as a nurse it's really important to distinguish between what's normal physical discomfort and what's a danger sign that warrants being evaluated. So kind of think about when you read about a symptom or you read about a patient's complaint, use your assessment skills to determine, is this routine or expected, or is this something abnormal? So these are very common decisions that patients, and this kind of gives you the pros and cons of things like breastfeeding, ambulating in labor, fetal monitoring, whirlpool or water, using water like hot tub jets and things in labor. Nor women and children's, they have a big gigantic jacuzzi tub and can have a water birth there. I don't know if Baptist does or not, and I don't think Norton Downtown does. Believe it or not, it's really interesting. They have certain rules about what the temperature of the water has to be and when you can be in there and have the baby actually within the water. Whereas other parts of the country, they don't have those rules. So if you have the opportunity, and they usually when they tour you, they'll kind of show you where that big water tub is at Northern Women and Children's. Analgesia is a big one. So again, we're thinking about pain medication there, whether you want an epidural. So if you've had any kind of spinal surgery, if you've had any kind of issues with your back, then again, we would want to have you consult with anesthesia during pregnancy. Another key thing that would alert you to communicate with anesthesia is if you're thrombocytopenic. Because if you have thrombocytopenia, a lot of times, depending on the cause of the thrombocytopenia and how severe it is, then you may not be a candidate for epidural. And then episiotomy. Very few people select or choose or want an episiotomy, but I do think it would be helpful to talk with the healthcare provider if they can already recognize it looks like you're going to have a big baby and you have a very long perineum, and so you're more at risk of tearing or having an episiotomy. All right, so let's talk about the first trimester. Nausea and vomiting is due to what hormone? It's a good thing, right? And so progesterone is pro-pregnancy. Progesterone is produced by the corpus luteum. And so in the presence of progesterone, that uterine lining stays thick and rich and vascular. Okay. So again, it's ready. So the pregnancy stays viable in that kind of rich uterine lining. And again, the pregnancy, the baby, the embryo, all of that is producing HCG. And HCG is what is giving us nausea and vomiting. So some people call this morning sickness, but some people have it all day long. It's not just in the morning. So what do you do for nausea and vomiting? One of the key things I would say is figure out what the triggers are. Believe it or not, in pregnancy, for a lot of women, it's actually good to have a little bite to eat before you get up and change position. So a little cracker or a little piece of toast before you get up out of bed. Separating your solids from your liquids. So in other words, you don't want to like drink ginger ale and eat toast at the same time. It's kind of like I eat my toast and I wait a little bit and then have small sips of clear liquids. For some women, the prenatal vitamin actually triggers the nausea and vomiting. So you want to think about what time of day you take the prenatal vitamin. If I take it at night, it doesn't make me sick. Hurrah! Do that. Okay? Because it doesn't make a big difference to us whether you take it in the morning or whether you take it in the evening, as long as you can take it. Some women cannot take prenatal vitamins. They end up taking children's vitamins. Again, hurrah. We'll take whatever we can get. pregnancy, very normal, but remember, you're just going to the bathroom a lot, but there's no pain, there's no urgency, there's no cloudy urine, your urine is clear and yellow, very normal and expected. Fatigue is very overwhelming, and so I think a lot of women are surprised at how tired they are at the very beginning of pregnancy. They expect it at the end, but at the beginning, they're just exhausted all the time. And so other people around you who don't know you're pregnant will say things to you like, honey, what's wrong? You haven't cooked dinner, you didn't fold the laundry, why are you so tired? It's just like, I don't know. But it's very normal, and again, the key thing here is to rest as much as possible. And so this might be a situation where you have a woman who may need to miss some work at the beginning of pregnancy due to the early symptoms of fatigue and nausea and vomiting. You're not able to work. Women are very cautious about this because I have a select amount of sick time that I'm kind of conserving to use after I have the baby. Depends on how long you've been working there, whether you have sick time or FMLA. So we have to be kind of judicious with that. Sometimes it's reducing the number of hours that you're working, but if there's things that we can do to minimize the fatigue and the nausea and vomiting, so she's able to function, take care of herself, take care of her family, we're going to encourage that. Breast tenderness, a nice supportive bra. So again, very common and normal. So touching the nipples, very sore, very tender. So again, I would just avoid that. Leukorrhea is the increased vaginal discharge. So it's, again, white, it's kind of mucousy, it's stretchy, it's not itchy, burning, or anything like that. Unfortunately, because of the changes in the vagina, she's certainly at risk for a yeast infection. So leukorrhea, normal, yeast, abnormal. Yeast is itchy, the consistency is different, it's creamier, tends to be in the folds of the labia. But I think, again, a lot of women expect itching, but it also hurts. So if you have a patient who's complaining of vaginal pain or vaginal burning, then we might want to see if yeast is there. Nasal stuffiness and epistaxis. Remember that runny nose is very common, nosebleeds are very common. So humidification is a good thing to do. Running a humidifier, cool mist, or steam. We sometimes will have patients use over-the-counter allergy medications, but again, we would really discourage that in the first trimester. And it's because we don't really have a lot of information about what's safe in first trimester. That said, some providers will give the okay for our patient to use that. So I would use as little as possible for as short amount of time as possible. So for example, you might have a provider who says to a patient that it's okay to use things like Flonase and Nasacort, which are nasal steroids to help with allergy symptoms, versus taking a PO antihistamine. That said, some of the medications that we use to help with nausea and vomiting are antihistamines. Unisom is an antihistamine. And so this is a very common combination of Unisom and vitamin B6. And it's available actually in prescription form so that you can actually take it as one pill. And it's very effective. And again, patients seem to respond well to it. We have not seen any long-term consequences from using that in first trimester. With nasal stuffiness and epistaxis, have you guys heard the latest about saline nose sprays? So we used to always tell everybody saline nose sprays, and now they're starting to think that it actually increases the risk of certain types of infections. And I think it's because their saline nose spray, they're sharing it with everybody in their household, and so it has pathogens on it, so it's just causing pathogens to go up into the upper airway. So there's some kind of new guidance about whether or not you should use that. Maybe the horror stories about neti pots and mold and things growing in neti pots because people were like pouring in and rinsing out their nasal mucosa, and you want to be careful that, again, you don't have risk of infection there. Botulism is increased salivation, and sometimes that causes nausea and vomiting. So chewing gum, sucking on hard candy can sometimes help with that. Rinsing the mouth out. If the patient does throw up or vomit, it's really important that she has good oral hygiene. So again, she needs to rinse her mouth out after she's sick, and then make sure, again, she's brushing her teeth. That said, for some women, the mint in toothpaste causes nausea and vomiting. And so if that's the case, then you can just have a woman brush her teeth and maybe not use toothpaste, but maybe just dip it in a but even just the action, the friction of the toothbrush should kind of get any debris off the teeth is better than nothing. But I would, be adamant about the Colgate if the Colgate is the stuff that's making you throw up your tonsils. So in second and third trimester, here's a list of very common conditions that cause discomfort in pregnancy. Pyrosis is the medical term for heartburn. So you take care of patients with heartburn. What do we do for patients to alleviate heartburn? What's that? Sit them up. Just keep in an upright position. Small, frequent meals, not big meals. Try to avoid things that trigger the heartburn or the increase of acid production. You probably had patients who used a lot of antacids and different GI medications to help with reflux and acid indigestion, things like that. Again, if it's okayed by the healthcare provider. Some of our providers here in town are very liberal and encourage the use of different things like Zantac and other types of histamine antagonists that help, again, prevent or reduce the amount of acid that's being produced. But on the other hand, you also want to be careful because a lot of patients will do it on their own because they think, oh, Tums is super healthy, it's calcium, I'll just eat this entire pack of Tums every day. That's not really helpful or healthy for you or your baby. So you need to ask your patient about that. That's way too much use of an antacid. And you know what having too much calcium can do. It can impact, again, your heart rhythm. It can impact, again, muscle contractions. We can have muscle cramping. And again, we need to find something other than it, because it takes that much Tums, something's not right. We need to investigate that more. Edema in the lower extremities, again, very common, particularly for patients who are up on their feet all day. And again, it should get better at night. Remember, the edema is due to the increased blood volume that's present. And remember, it's a gradual increase as you go through pregnancy. So we're much more likely to see that in the third trimester than it would not be normal to see that in the first trimester. Does that make sense? Because in the first trimester, the volume has not really started to accumulate, and cardiac output is not quite increasing in the big changes that occur as you get closer to third trimester. So because of all that venous congestion, that then contributes to varicose veins, hemorrhoids, and then with that, for patients who have varicose veins, what do you do for patients with varicose veins? You have them elevate their legs and get off their feet as much as they can. We never want to massage varicose veins because any massage at the lower extremity may cause the dislodging of a DVT, which would cause the clot to move and cause other complications. Some people use compression stockings to help promote venous return back, so they might wear TED hose and different things to help. But again, kind of more if you can exercise, but the key with pregnancy is to put those feet up, and they got to be above heart level to try and get blood flow back to the heart. Constipation we've talked about. It is very common for women in pregnancy to use stool softeners and also over-the-counter like Fibercon, Citracel, Metamucil, things like that to make the stool softer and easier to pass. We want to discourage women from using the Valsalva maneuver, which is where you hold your breath and bear down for a prolonged period of time. Backache. So this is one that you have to be really cautious about because backache can be very normal in pregnancy. And again, it has to do with that sway back. Okay, so you're carrying more weight and you have more pressure on your lower back. Now, backache that's centered in the middle of your back, okay, it's often either a sharp pain, comes at the end of the day, it's, again, doesn't move or radiate. That's pretty normal or expected. Versus a dull, achy pain that starts in the front, radiates to the, or starts in the back, radiates to the front, or starts in the front, radiates to the back. That would make you think contractions, which are not good. That's not a good backache to have. For some women, when they have those early contractions, they actually just feel pressure changes, but it's not something that position alleviates. When you have a normal backache of pregnancy, a lot of times positioning will help alleviate that. So you'll see different things like pelvic girdles and belts that take the weight off the uterine ligaments. We'll have patients do different exercises. So they'll kind of do lots of yoga stretching, but if they can get the weight of the uterus off the back of their spine, that will alleviate back pain a lot for women. Leg cramps, very common in pregnancy, so hydration is essential during the day. And again, avoiding things that would make getting rid of sodas, and then making sure, again, that you have, again, adequate nutritional intake throughout the day. Exercising, using your legs. Some women have more restless leg syndrome in pregnancy that they did not have outside of pregnancy. So again, the more active you can be during the day, that will help minimize leg cramps at night. Passing out or being faint, what do you think is the cause of that in pregnancy? Orthostatic hypotension. So what do we do for that? Change your position gradually. You got it. And again, I think a lot of women who are pregnant feel like people kind of baby them or treat them like they're fragile. And we're not trying to treat them as if they're fragile. We're just trying to assist. And I think it's this idea of just making kind of minor modifications in my behavior so that I maintain my safety for myself and my baby. So again, we tend to be rush and hurry, and yes, I'm quite capable of, zipping across the room and catching that door, but I just want to be cautious in how I do that, being kind of more mindful because my center of gravity has changed, my balance has changed due to pregnancy. So dyspnea means that I might get out of breath doing something very sudden. Again, I have increased needs for oxygen for me and my baby, and so then when I run or I cause some type of stressor, I get short of breath easily. So I need to allow for that. I may need to modify my exercise activity to, again, change what I'm doing. For people who exercise in pregnancy, one of the things that we watch for is their temperature, their heart rate, and their respiratory rate. And again, we can allow for certain kind of elevations of that, but there's a limit. So in other words, the OB will kind of guide the patient as to how high her heart rate can be, how high her temperature can be, how fast her respiratory rate can be. And it may be that she has to modify her exercising. So maybe instead of running, she walks, or maybe she swims, or maybe she does bicycling instead of running. And some type of different type of activity, again, to kind of keep vital signs within the prescribed parameters. Difficulty sleeping is a big, big deal. So some reasons why women can't sleep in pregnancy: worry, anxiety, fear. So we need to address mental health concerns. I think everyone assumes that pregnancy is a happy time, and for a lot of patients it is. But I think you want to talk about the things that you're scared about. Is my relationship going to be the same with my partner? How are we going to afford this baby? Can I go back to work? Do I want to go back to work? I always said I wanted to be a mom, but now I'm scared. My mom calls me every night. It's driving me crazy. It's those kinds of things that cause for women and women's partners to lose sleep. When you lose sleep, you're grouchy and you're irritable, and you often don't want to take care of yourself. When you don't take care of yourself by eating right, getting good rest, doing your basics, it begins kind of a vicious cycle. So sometimes just something as simple as having the patient's partner kind of call a timeout, and instead of running everywhere, let's just stay home, let's rest, I'll cook dinner, I'll take care of laundry, we just meet the basic needs. And you kind of allow that time for that resetting. But it's normal to have periods of insomnia in pregnancy. The problem is if you have so much insomnia and you're chronically sleep deprived that you have a car accident. So you have to watch and make sure that that chronic fatigue and sleepiness is not dangerous. Round ligament pain comes from the uterine ligaments. Again, we're going to see that later in pregnancy. Round ligament pain is often unilateral, meaning that it's on one side. And so again, position changes can help with that, getting the weight of the uterus off of the ligaments. Round ligament pain can be in the front, and again, it tends to be sharper pain, and it's constant, it's not intermittent. Intermittent pain that comes and goes, we think more contractions. And then carpal tunnel syndrome, we talked about how you can have different paresthesias. So with carpal tunnel, it's folks who have a lot of fine motor, and so they have numbness and tingling here. So for carpal tunnel, we often use an immobilization device, and that helps alleviate the pain that the patient's having in their wrist. So again, these are just showing you some basic things that you can do. Remember, when we have a patient who is in the second, third trimester, we never want her flat on her back. So you always want to put a wedge or have her on her side, and that prevents the compression of the vena cava. Making sure that you lift with your large muscles in your legs and your arms and not in your back. And again, being mindful of how much you carry in terms of toddler and carrying laundry at the same time down a flight of stairs, that's something different. So maybe you need to make fewer trips, leave the laundry up at the top of the steps, maybe someone else can help bring that laundry down the stairs. All right, so fetal activity monitoring. So again, the time frame here is a little bit variable, so we're going to say somewhere in the neighborhood of about 24 weeks or so. It's right at that viability. That is in the second trimester. That is in the second trimester at the very end. Now, moms should start feeling movement somewhere around 20 weeks. First-time moms will feel it a little bit later than moms who've had a baby before. So if you're a Gravida 3 para 2, you might come in at 19 weeks or 18 weeks and say, yeah, I've got some flutters, okay? We are not doing daily kick counts at 19 weeks. The baby's moving every day, but it's not big enough for me to perceive that. So we wait till we get to this viability point before we really start doing kick counts. So the OB provider will instruct the patient about how to do kick counts, and there's a couple different ways to do it. One way is to count how many minutes it takes to get 10 movements. Another way to do it is to count for 30 minutes, how many movements you feel in 30 minutes, okay? The key thing is that we want to feel distinct movements. There needs to be more than one, and it needs to be checked on a daily basis. Now, sometimes moms get really scared because they're like, gosh, I can't remember feeling the baby move. So when should you do this, and how should you do this? It's best if you do it at the same time every day. It needs to be done after you have eaten something or had something to drink. So a lot of times people will do it at the end of the day. That said, your baby has circadian rhythms kind of like you have circadian rhythms. And again, a lot of times the baby's moving, but you're so busy, so it needs to be a time that you can be quiet and kind of pause so that you can pay attention to picking up fetal movement. So you want to empty your bladder, have something to eat or drink, lay down on your side, and usually we'll tell women to lay on their left side. Now, if it's more comfortable to lay on your right side, can you lay on your right side? Sure, okay? But again, it's kind of tuning in and making sure you're keeping track of fetal movement. And so, let's say that the mom calls you, you're the triage nurse, and she did all of those things, and she's been assessing kick counts for about half an hour, and the baby has not moved. So she calls you. What would you recommend to the patient? Well, actually, you would just reassure the patient the baby has sleep cycles. They are shorter, so the baby shouldn't sleep for 8 hours, okay? So I would just continue resting on the left side, continue to eat and drink something. Sometimes, again, maybe mom's a little bit dehydrated. Make sure you have something that has a little bit of sugar or a little bit of carbohydrate in it to try and wake the baby up. And I would just continue to wait and wait again another hour to see if the baby wakes up and moves. The other thing is you want to ask about mom's behaviors, because mom may have done all those things, but right before she did that, she smoked a cigarette. And when she smoked a cigarette, it decreased the circulation to the baby, and so the baby's not getting a lot of oxygen, so that's why the baby's not moving very well. So again, and a lot of women don't admit that, so you would need to ask, have you smoked a cigarette or had any medication today that may have impacted the baby's movement? Now, hour and a half later, she calls you back. She's 29 weeks. She's routine, normal mom. She calls you back and said, I called you 90 minutes ago and said the baby wasn't moving. The baby's still not moving, okay? Generally, what we would do then is go ahead and have mom come in, and we would do some fetal monitoring. But a lot of times, once mom gets to the hospital, when they monitor the baby's heart rate, the baby's doing fine. But if mom has decreased fetal movement and she's done all of those steps that we've talked about and still is not feeling the baby move or has decreased movement, then she needs to be evaluated. Okay? But 9 times out of 10, you can take care of it by mom just needs to be fed, watered, and rest, and just being tuned into movement. Okay? In terms of breast care, remember that it's common for women to leak a little bit of colostrum. So if they do, they need to put kind of a breast pad inside the bra, make sure they're changing that regularly, keep it clean and dry. And again, wear a firm supportive bra. Their bra size may increase throughout pregnancy. And just because you're wearing one size of bra in pregnancy, postpartum it may get even bigger. So So again, you may need to adjust and go shopping for appropriately fitting undergarments. So a lot of women will ask things like, I sleep in a sports bra, is that okay? And that's perfectly fine, whatever's comfortable for you. Some women, they feel better actually sleeping in a bra because it supports the breast, and so they don't get as much pain and discomfort there. In terms of clothing, certainly inexpensive clothing, stretchy, easy to fit, get around your belly. You don't want to wear tight, constrictive clothing. Patients who wear too tight of pants and stockings and things like that, it can predispose you to things like urinary tract infections. The other thing is hygiene is really important because remember, women often are sweaty in pregnancy, so they need to do laundry and change their undergarments more frequently. So let's talk about bathing. Again, there's some studies that show taking repeated hot baths in first trimester can harm the developing fetus. So they recommend excessive use of hot tubs, particularly in first trimester. Now, if a mom calls you as the triage nurse in tears because she went to Gatlinburg and over the weekend she was in the hot tub and didn't know she was pregnant, I don't think the one-time use is going to, harm her baby in any way. So just reassure her that's okay, and now that you know. But again, the idea is to really avoid a lot of hot tubs at the beginning of pregnancy. The other thing about bathing you have to be mindful of is safety, prevention of falls. So getting in and out of the shower. If mom has any type of trauma or fall and hits her abdomen, we want her to come in and be seen and be evaluated to make sure that there hasn't been any harm to the baby. In terms of employment, some jobs are risky as a pregnant person. Nursing is one of them. So if you're a pregnant nurse, what are some employment risks that you may encounter? Injury, back pain, so musculoskeletal, bloodborne pathogens, any kind of pathogen, so infection. Because remember, certain types of infection can cause genetic disease. So that's one of the reasons why we always have all our titers drawn to make sure we're varicella immune, rubella immune, all those kinds of things. But CMV, for example, cytomegalovirus, I would not want to take care of a patient who was in isolation for CMV if I'm in the first trimester of pregnancy. So again, I may have to then reveal that to my charge nurse to say I'm not going to be taking care of that patient. The other thing is, think about some of our oncology nurses. They're taking care of chemotherapy agents, which again can be harmful to a developing fetus. So pharmacists is another, and the safety precautions that they do with the hood and the chemicals to minimize the exposure there. If you're in any type of field where there's trauma, injury, so again, as a nurse, unfortunately, more nurses are getting attacked in the workplace by visitors and patients and other folks. We have to be mindful of that. Stress. So you might have stress, and again, shift work puts you at greater risks than someone who kind of works at normal. So I think those are a lot of things to think about in terms of taking care of yourself and taking care of your baby when you or your partner is having a baby. The other thing for nurses, you will see some nurses who will shift to light duty during pregnancy, and that's another common phenomenon that occurs. Some women actually go on disability during pregnancy because of the restrictions they have placed on them. So for example, let's say that I have twins and I have preeclampsia and I'm a nurse. I can't work in the ICU. I'm going to be at home on bed rest for probably until I have the babies, which could be 4, 6, 8 weeks. So I go on short-term disability to help offset some of the costs from not bringing in the income. With employment, it's important to know that you can't be discriminated against due to pregnancy. However, there are all kinds of stories coming out. I just read one about horrible things that were going on in Memphis about women being discriminated against. They reported that their physician gave documentation about being on light duty, and the light duty restrictions were not followed. So if you have someone come to you that says they need to be on light duty related to pregnancy, it's important that you follow the guidelines expressed in the physician's or the healthcare provider's limitations. A lot of it has to do with lifting, being on your feet a certain number of hours, and then also access to the bathroom, emptying your bladder frequently. Those tend to be the most common things in pregnancy. So travel, one of the big things about travel, we have to think about the risk of Zika. So we would discourage women who are either thinking about having a baby or very early in pregnancy, traveling to areas in particular where Zika is prevalent. So we do tend to see that kind of more in Central America, at least from this side of the globe. And they would want to ask a patient if she has traveled to an area where Zika is present, then we might do some further testing to make sure that we're not seeing any type of neural tube defect. But you also want to think about travel to other places. And then some of it is the traveling itself that could be risky. For example, a patient who flies a lot, is a business person and has to fly everywhere, is going to be a greater risk for developing blood clots in the lower extremities. So getting that patient up, walking around, doing range of motion to prevent venous stasis in the lower extremities. The other thing is she may experience dyspnea with the pressure change in the plane. So whether you are fly or drive or whatever, again, safety is critical, making sure you wear seat belts, change your position frequently, drink lots of fluids, empty your bladder. Again, if you are traveling in the third trimester, sometimes you might want to take copies of your prenatal records with you to be able to give to the doctor there. So, sorry, hang on just one sec. Okay. So traveling is okay. Let's say you're the triage nurse and the patient and her husband ask, can we go to Gatlinburg when she's 32 weeks pregnant? The answer is yes. Can they go to Disney World at 32 weeks? Yes, absolutely. Even flying on a plane now, there used to be some restrictions about flying on planes that you couldn't fly after a particular gestational age, and some of the airlines have changed that restriction a little bit. The key thing is you always want to be prepared that if something happens, that you have those records there so that way the person who's taking care of you knows how to care for you. So we sometimes see patients here, especially around Kentucky Derby, that are from all over the country, but they had a complication develop related to pregnancy, and so they come in and see us as OB providers here in Louisville. With activity and rest, you have a patient who's been exercising and active. Often patients can continue that exercise during pregnancy. We actually like exercise during pregnancy. However, it's not the time to start a brand new exercise program. So in other words, you would not have somebody with a sedentary lifestyle all of a sudden be training for a 10K, okay? And think, oh, I'm gonna get super healthy now that I'm pregnant. Let's look at something a little bit easier. Again, I think yoga, walking is good, low impact type exercise, stretching is good, flexibility is fine. Now let's flip it around. We've all seen the pictures of our, marathon trainers who, ran a marathon and then 2 hours later was, running at 38 weeks and got that little belly just, and then they went and had baby. So there's people who are able to exercise strenuously, successfully in pregnancy. So I think, again, it's just being mindful of asking your patient what they do and what types of activities they do. Self-monitoring is key. So again, monitoring temperature, heart rate, and respirations. Again, temperature is more of an issue in first trimester. The other thing is dehydration. You want to make sure they're getting enough fluids. So with patients who are avidly exercising, tell them to put even more fluids in because they can easily get dehydrated. All right, we are at 1:15.